review. May I now invite Dr. Elsie Chan to speak to us about keratoconus? Is she on the...
Yes, I'm here.
Okay.
Sorry,
Yep. There you go.
Sorry, I just had to wait to share my screen. Can you see that all right?
Yeah.
Great, thank you. So thank you so much for inviting me to be part of this symposium. And I've chosen the topic of keratoconus because I feel that keratoconus is still a really undiagnosed condition. So I wanted to share with you some of the most important points about keratoconus, and in particular, epidemiology and prognosis after cross-linking. So keratoconus is actually much more common than people realize. There have been a number of prevalence and incidence studies published in the literature that range from different countries, 1 in 375 in the Netherlands, 1 in 2,673 in South Korea, to 1 in 191 in New Zealand. Each of these studies have suggested there may be differences between different countries, but at the same time, there's also a different methodology employed to determine the prevalence. So I've been very lucky to have access to an amazing study called the RAIN study, which is based in Perth in Western Australia. And this is a multi-generational longitudinal cohort study, one of the largest pregnancy cohort studies in the world. And in 1989, pregnant women and their newborns were recruited for this study. And we've been fortunate that after all these years, those children have now turned 20 and 28 years with time, and they've had shine plug imaging performed at these 2 time points. And so when we looked at the prevalence amongst the 20-year-old adult when they turned 20, we found that the prevalence was 1.2%, which equates to 1 in 84 of the participants. When these participants reached 28 years, we found that the prevalence was 3.4%, or 1 in 30, making an incidence of 2.2%, or 15 additional cases between 20 and 28 years. And this incidence and prevalence is one of the highest reported in the world. So my first learning point is keratoconus is much more common than previously reported. And I think those of you who do cataract surgery and do a lot of toric IOLs will also notice that when you perform corneal tomography or topography, this is indeed the case. So who should you be thinking about screening for keratoconus? I think it's important to remember that while we typically think of keratoconus having its onset in the 2nd decade of life, so when someone's a teenager after puberty, the youngest reported age in the literature I could find was 4 years, whereas the most youngest patient that I remember seeing in the last few years was this 10-year-old whose images you see here, where they presented with unaided visual acuities of 2 on 60 on the right and 660 on the left. And it's important to remember that children who are diagnosed at a younger age tend to have more severe disease on presentation and more rapid progression. So it's very important to diagnose them when they're young. In terms of the ethnicity, there is in the literature, it appears to be more common in those who are from an Indian or Pakistani background, who are Black, Hispanic, Maori, or Polynesian. We know it's more common in those who have a family history of keratoconus. And in a New Zealand study, they suggested that 1 in 3 people who have Down syndrome also have keratoconus. It's also associated with hay fever, eczema, and asthma in many studies, and allergic eye disease, eye rubbing, and as Professor Claire Fraser just mentioned, sleep apnea can cause multiple problems, and it's also associated with keratoconus. There's also biomechanical associations as well. One of the problems with diagnosing keratoconus, however, is that there's no consensus on the diagnostic criterion. And in addition, there are no signs in the early disease. So I recommend you screen your patients if they have risk factors for keratoconus, especially if they're young and they've got increasing astigmatism, or they've got decreased vision and a normal clinical exam. So how do you diagnose keratoconus? Corneal tomography remains the gold standard, where we look for posterior elevation, abnormal thickness distribution, corneal thinning. For those without corneal tomography, then using a retinoscopy, looking for a scissor reflex is also useful. And I think the future lies in machine learning. So my second learning point is screen children with risk factors. In managing keratoconus, there are of course two important aspects. One is to stop progression and the other is visual rehabilitation. And I'm going to talk about cross-linking and not going to talk about visual rehabilitation because of the time. So keratoconus can be managed with cross-linking to stop progression, as you all know. And in actual fact, this year represents the 20th anniversary of the first paper that was published on the use of cross-linking in clinical practice in 2003. So this many years on, we're starting to get more publications looking at the longer-term follow-up of cross-linking. Looking at these 3 studies, which have been published with more than 10 years follow-up, the interesting thing is the keratometry values and the corrective visual acuities actually improved throughout those 10 years in most of these studies. Not unexpectedly, there are a few cases that progress. The stories are slightly different in the pediatric cross-linking population, whereas you can see from these 3 studies, it's quite amazing that the number of patients who stabilize, it was almost identical between the studies, between 76 and 79%. But this does mean that when you're treating a younger patient, the parents should be clearly informed at the time of cross-linking that 7 to 10 years down the track, treatment could potentially be repeated if necessary in nearly 1 in 4 of these patients. In Melbourne, we've been very fortunate. We published as many of you who follow the cross-linking literature, we published our randomized controlled trial of cross-linking many years ago now, and we've been performing cross-linking since 2006. So what I've done is I've invited some of those patients back to our hospital and tried to see whether they had been stable over this. 4 patients back from our original trial who've had follow-ups ranging from 7 to 13 years after their treatment. And looking at their results, looking at the K2 value, which is the steepest keratometry and the steepest axis, we found that all of these patients have remained stable since treatment. There's been 1 retinal detachment following cross-linking, which I don't believe is related to the treatment. No cases of persistent haze or scarring. No patients have required a repeat cross-linking. And more importantly, no patients have required a transplant. With corneal transplants, I then decided to look at the number of transplants being performed for keratoconus in Victoria. And as you can see, when we started to perform cross-linking in 2006, over this period of time, I think we've got long enough to see a real downward trend in the cases performed for keratoconus. My learning points for you are keratoconus is more common than previously reported. Screen children with risk factors, and cross-linking is effective, but please monitor your pediatric patients for longer because they may progress. Thank you.